Thank you, Peter. I'm just going to share my screen. Okay, can you see that? Yep.
Yeah.
Excellent. Thank you very much. So again, thank you for that introduction, Peter, and thank you everyone for coming along this evening. So before I get started, I would also like to acknowledge my local Aboriginal community, so the Palawa Pakana people. I'd also like to offer my thanks for the care of country for thousands of years and pay my respects to their elders and ancestors and their legacy to us. I'd also like to acknowledge lived experience. So I'd like to acknowledge and convey my appreciation for the contributions of people with lived experience. Hearing and listening to the voices of our consumers, so patients, families, carers and supporters, is imperative for meaningful health service improvement. So for this evening's masterclass, I'm just going to give a little bit of an introduction to Healthcare Redesign for those of you who haven't heard it before. I'm going to talk about flow and waste and really go into a bit more detail around the 8 wastes in healthcare. I'm going to have a quick look at the options for studying healthcare redesign and health service improvement with the University of Tasmania, and just touch on the advanced practice model and the health service improvement specialisation that Peter just introduced. Okay. So just to get you thinking about how systems and processes underpin health service improvement, I've just included this quote from Don Berwick. So in order to make meaningful change in health services, we really need systems and processes that work, so that are effective, that are efficient, and that are also sustainable. So healthcare redesign itself is an approach to health service improvement that focuses on problem solving, so understanding and diagnosing problems, developing evidence-based solutions, and implementing and evaluating those solutions. So we really use bottom-up initiatives, and we try to see things through the patient's eyes to find better ways of doing things. And this allows us to look at the whole picture, and it also allows us to consider and think about the ideas and work of others around us. We also want to give frontline staff the time and tools to tackle the problems that they've identified. So although there are 5 phases to redesign, today I'm really going to focus my discussion on sort of the front end, if you like, so the scoping and diagnostics phases and the information or evidence gathering. So scoping is really about defining your problem or developing a problem statement, as we like to say. If you don't know what your problem is, you can't build a case for change. You can't gather data or evidence to support change, and you have no way of measuring whether anything you have done has actually made any difference. So I'm sure if I asked you to think about a problem that you might currently have in your work area, you might be able to come up with something or a few things. But it's important to remember that we are looking at problems, so not solutions. That comes a little bit further down the line. So when you've defined your problem, it's easier to explore root causes and to engage with people who are involved in that problem. The diagnostics phase is then about understanding the problem. Understanding its causes from the perspective of patients and families, the perspective of staff, and also from the organisational perspective. So within this diagnostics phase, we use a range of tools to gather data about the root causes that we've identified. So we generally use a root cause analysis to tell us where we should start looking for evidence to support that problem. And just really briefly, the following phases involve designing solutions to the problem you've identified based on the evidence collected within that diagnostics phase and engagement with relevant people, implementation of those solutions, then change management strategies, implementation science, and a sound understanding of barriers and enablers local to your own work area where you're implementing change. And then we look at designing an evaluation that measures sustainability and continuous improvement based on that implementation. So getting back to the problem, just as an example, I've put a couple of problem statements up on the slide here. So the first one suggests someone's manager has come to them and said, I want you to introduce team-based care. So straight away, that's actually a solution. That's not a problem. But the problem might actually be that the current systems and processes with communication between clinicians seems to have a detrimental effect to the patient journey, potentially resulting in long delays and the potential for adverse events. So we've flipped that around to really define what the problem is and not coming into that with a solution. And the second example, my CEO said I had to update the policies and procedures about infection control as my project, when potentially the actual problem could be the current systems and processes in infection in practice and potential for real or adverse events. So in both of those scenarios, updating the policies or introducing team-based care may end up being one of the solutions based on the information that you collect, but they also might not. So there are three major issues that arise when people are trying to define a problem, particularly in healthcare. So something to think about next time you'd like to make a change. So don't assume you know what the problem is without looking at what is actually happening. Don't assume you know how to fix a problem without finding out what's causing it. And don't assume that the action you've taken to fix a problem is working without checking if it's doing what you thought it should be. So identifying a problem is the first practical step in redesign, but there's also a range of theories that underpin this approach to change. So lean, which I'm sure you've heard of, or lean thinking, although originally developed as a manufacturing process, has been successfully applied to healthcare in some cases. In my experience, if lean fails in healthcare, it's generally not because the approach doesn't work, but it's because the problem hasn't really been well defined. So lean applies to problems where you want to reduce waste and improve flow of systems and processes, and it's not going to work in all types of change. Similarly, Six Sigma is an approach for reducing variation in systems and processes. If the problem that you've identified focuses on variation or streamlining processes, then this is the approach that will probably work best. And the theory of constraints is another approach that can be used in redesign, where systems and processes have immovable constraints, so things that you just have to learn to work with. So again, the theory underpinning your own redesign will depend purely on the problem that you've identified. So Six Sigma is reducing variation, and that's a data-driven approach focusing on quality of systems and processes. So lean is about removing waste and improving flow, and it looks at the value of each step in a process. And the theory of constraints is around exploiting constraints and working with what you have. So all of these theories can be used to redesign systems and processes within current resources. Making change in health services doesn't necessarily mean more money, more staff, or more beds. It means being more efficient and more effective with your existing resources. So in Australia, there are some general drivers for health service or healthcare redesign. And these include things like national targets, our ageing population, access, the burden of chronic disease, and of course, the increasing cost of service delivery. So one of the ways in which increasing costs can be mitigated is through the identification and removal of waste in systems and processes in healthcare. So that is systems and processes that don't add or add very little value to the consumer journey, whether that's the patient journey, a staff member's journey, or the organisation more broadly. So for the next part of this session, I'm going to focus on waste in healthcare based on the principles of lean thinking. But before we jump into waste, I just need to briefly touch on flow. So flow is essentially how things move through a system. So improving flow for patients is about reducing the amount of time that patients are sitting, waiting for someone to care for them. Flow improvement comes from eliminating waiting, eliminating interruptions, eliminating delays. And good patient flow in an acute hospital is really concerned with ensuring that patients experience minimal delays throughout the whole hospital journey. So that could be from the emergency department to the ward, within outpatients, or when they're being discharged to a suitable destination. So flow can be improved through the use of a range of tools and techniques. Just one example is batching. So batching is when we save one job to do all at once on one day or at one particular time period, rather than doing things as they come in. So just as an example, processing of outpatient referrals, all done on a Friday morning instead of as they come in each day. Even doing them, say, in the last hour of each day, although that's still a form of batching, it actually adds more value to the patient journey, because patients are still getting an appointment earlier than what they would be if those batches were done just once a week instead of once a day. So waste, what is it? Identifying waste in health systems and processes is one of the most effective and efficient tools for redesign, which can result in better utilisation, as I said, of existing resources. So waste is any activity that consumes resources but creates no value for the customer or the patient. A couple of things to consider when we're looking at waste in healthcare. So people aren't waste. People don't come to work to produce waste. Waste is generally the result of systems and processes that aren't working as they should, or that just don't work at all. And waste impedes flow. So impeding that flow then has the flow-on effect of reducing that value again for customers, so for patients, staff, contractors, organisation, whoever that might be. Using the acronym downtime, we can identify and categorise waste into 8 areas. So I'm just going to briefly go through each of those individually and provide a couple of examples of each. But as I work through them, have a think about the types of waste that you have in your own workplace or in your own practice. And feel free to add them into the chat. I'm sure there are some universal types of waste, but there will also be some that are more specific to particular systems and particular processes. So the first one is waste of defects. In this case, a defect is an error or a mistake that's made. So this refers to any activity where time, money, or other resources are wasted in order to either identify or correct mistakes. So when someone has to repeat the work again, we're wasting these resources. So it also refers to mistakes that lead to adverse events and have to be repeated. So for example, having to take blood again from a patient because the incorrect path tube was used, a surgical cart that might be missing an item, or the wrong medication or a wrong dose of medication that was given to a patient. Overproduction refers to the delivery of services faster than needed or sooner than needed, or delivering more of a service than needed. So for example, unnecessary diagnostic procedures, making a meal that a patient doesn't eat, performing chest x-rays every day on every patient in an ICU, or keeping a urinary catheter in for too long. So they're all examples of overproduction. Waste of waiting, fairly self-explanatory. So it's time lost when people, facilities, or equipment are waiting. So for example, patients waiting for an appointment, people waiting for a meeting to start, theatre underutilisation, outpatient did not attend, staff are waiting in that case, or surgical wait lists. So waste of non-utilised people. So that refers to people whose skills or talents are not being respected within the workplace or not aligned with the work that they're doing. So really about not using people who do the work to improve the work. So some examples are underutilising clerical or administrative skill sets. So for example, in outpatient department, an administration staff member approaches a NUM or a registrar or a consultant about making some changes to how appointments are booked because he notices that patients are waiting on average 2 hours for their appointments on a Friday. So they don't give permission for this to be investigated or for change to be made because, and I quote, "It's not your job to know how we schedule our patients." But actually that person's probably the best placed person to make that change from a patient perspective because they work with the patients in that process and they understand the systems and processes that underpin that administrative process. So obviously they would engage widely around that, but they do have the skills to undertake that change. So waste of non-utilised people often results in burnout or staff leaving because they don't feel valued or respected. So waste of transportation is when patients are transported around the hospital or across the state. So, for example, transferring to a bigger tertiary referral centre for specialist requirements. It can happen as a result of poor layout, such as a catheter lab being located at the other end of the hospital from the emergency department. So the patient essentially has to be transported backwards and forwards. Waste of inventory, also fairly self-explanatory. So that's any material in excess of what is required now for the care of patients. So, for example, keeping large amounts of stock just in case it becomes unavailable. So usually because you don't trust the supply chain. But that then results in expired stock that needs to be disposed of. So another example is excess emails. So that's considered inventory as well. Or things like pre-printing forms that might not be used. So the waste of motion, it's different to the waste of transport in that motion is about the movement of people or equipment that doesn't add value. So, for example, nurses who spend most of their time in the corridor looking for things, ambulance officers moving equipment from one truck to the next, laboratory employees walking miles every day because of poor layout of the lab, or even searching for information in a medical record is considered waste of motion. So I'll just put a spaghetti diagram up on this slide. It's a really good way to visualise the waste of motion by tracking people as they're walking to wherever they need to go. So you can see in the top one there, the before, after change, there was much less waste of motion. So waste of extra processing is activities that do not add value from the customer or the patient's point of view. So, for example, readmitting a patient to another hospital, outpatients repeating tests that were done by the GP, or asking patients to fill out duplicate paperwork. So essentially it's doing more work than is actually needed. So in redesign, looking at waste in healthcare is about improving flow. So identifying where that waste is, what's causing it, who's involved in it, and then using solutions development tools and techniques and implementation science to make sustainable change that will add value to your patient or other consumers' journey. So as I said, it's part of lean thinking, and it is only a part of redesign. There is a whole other gamut of evidence and data collection that can be done to complement and supplement this part of it. But that will depend on the root causes that you've identified as part of defining your problem. And you may require different strategies and different tools to investigate those. So the University of Tasmania has a range of options for undertaking study in healthcare redesign. We have a free, massive, open online course, or MOOC, that's available to anyone at any time, and it's not time limited. So the content takes around 18 hours to complete. We recommend about 3 hours per week over a 6-week period. There are 6 modules within that. So this is a bit of a taster for what you can expect to study in the Graduate Certificate of Healthcare Redesign. The MOOC also covers the waste in healthcare content in a little bit more detail. So if you're interested in having a bit more of a look at that, I would recommend jumping on and enrolling in the MOOC. The Graduate Certificate then is a project-based work integrated learning course where you will be supported through a redesign project in your own workplace, developing knowledge and skills in redesign, in project leadership, change management and implementation science. So our team also have a partnership with the Agency for Clinical Innovation in New South Wales, where they facilitate a large number of projects through our course, through the graduate certificate pathway each year. So the newly developed advanced practice model, which Peter has already provided a bit of an introduction to, then offers broad opportunity for further developing your skills, specialising in a number of streams, but including health service improvement, which is the natural progression from the Healthcare Redesign graduate certificate. So this specialisation focuses on the post-project phase, looking at strategies for evaluation in health services, so using things like program logic, as well as how national standards influence health service delivery. So this model allows you to select elective units depending on what aligns with your own work needs and with your own interest. And it's a great way to build on your redesign skills and knowledge. So some of the other specialisations, some of the other specialisations that are available, as Peter said, are governance, workplace psychology, clinical education, and supply chain and logistics. So if the project-based graduate certificate in redesign doesn't quite align with your role or with your needs at the moment, there is an option to complete that grad cert in advanced practice with a bit of a choose your own adventure pathway. So you can choose from a range of units that suit your own needs and then progress into one of the specialisations such as health service improvement instead. And for anyone who's not familiar with the postgraduate study pathways, I just thought I'd pop this slide up. So the graduate certificate is the first 4 units in postgraduate study, and then a further 4 units will get you a graduate diploma. And then next year, a further 2, 3 or 4 units, depending on what pathway you choose, will get you up to that master's level. And also, as Peter mentioned, for anyone who is interested then in pursuing further higher education by research, redesign actually opens a wide range of doors with a whole range of projects around health service improvement. So currently we have a number of PhD candidates who have come through the redesign pathway. And a couple of those projects include looking at redesign and leadership and how they intersect, redesigning the emergency departments in Tasmania using the clinical pathways for stroke, sepsis, fractured neck of femur, and cardiac pathway. And most recently, our team have advertised for a full-time PhD candidate to undertake an implementation science research project in Tasmania's emergency departments as well. So if you are interested or know anyone interested in a PhD, we are currently looking for candidates for that project as well. But studying healthcare redesign can lead to a whole range of different areas and can be useful in any clinical or non-clinical area within health services. And that's it from me, Peter. Thank you.